So you, yes.
We'll click on those for number 7. If you didn't note to change anything, it's just for our information.
Right, if I say no change, if on the little table,
Yeah.
you're nothing to redo but no. Okay. Would you bring these back next week, next Monday? I don't see you again for quite a while, so I'll either have Dr. Britton pick them up, because you have a test on Monday, correct? Or I'll come over it when he does his introduction. So why don't you bring it for the introduction to psych, behavioral health, at 1 o'clock. All right, headaches. So so you did headaches at, right before this? Okay. Did Dr. McNeil do pathophys of headaches? At no point, nothing, he didn't do migraine pathophys?
Well, the headache guy kind of gave us the pathophys of it.
Okay.
Briefly, like 2 sentences.
Okay. I did put a big section in your handout on it, several pages. It's just not one that I am as not up to date. I just have never studied it to a great extent. I'll go over it with you, what I understand. You've got it there. I'm not going to test you on it, but it's helpful because there's been a lot of change in our understanding of migraines. When I sat in your place, it was vasoconstriction and vasodilation. That was it. Well, we know a lot more now, and our drugs have changed because of it. Okay, so we'll go through that some. All right, so what'd you learn about migraines? They start with a trigger. Okay, which neuropeptide usually? Serotonin is your biggest one, okay. Vasodilation leads to migraine. Okay, what else did you learn?
They would have an aura.
They can have an aura. So what's an aura?
I think it depends on the person, but like they got a fuzzy in their eyes or a weird light or darkness or tunnel vision or yeah, auditory.
Okay, so it can be multi-sensory. Okay, and does everybody have an aura?
No.
No. So there are migraines with aura and there's migraines without. And even in the migraine with aura, in the classification, did y'all go over how the diagnostic classification? Okay, I've got it in your handout. The other thing is I will post for you the International Headache Society, and they just this year, and I updated your diagnostic criteria because it changed from last time for 2018, the criteria for migraine, then they have migraine with aura, and then they have what they call, they've broken down the aura into 2 separate groups. Migraine with aura and then migraine with typical aura. So we'll go through that. They just vary in terms of what part of the brain or what mostly is involved. Okay, what else? Migraines. Who's mostly affected?
Women.
Women. What's the kind of the ratio?
Second, third, of life, sorry.
It's about 3 to 1, second or third migraine. Second or third generation. Okay, what else? What else in terms of who's likely to walk into your office or in your urgent care or your emergency room?
If they've had it for, say, 48 hours, or if it's different than what they're used to.
Okay, and he was an ER person?
Yes.
Urgent care? Okay, all right.
He's the director of NSU.
Okay, okay, so does he do the nursing school up there?
He's
He's
a
in
PA.
PA.
They're starting a
Oh,
PA.
they are?
Yeah.
Really?
They're
Wow.
taking their first applications.
Okay. Well, they have a nice little campus, not bad. Okay. They have a nice setup up there. Okay, good. Okay. So in terms of how are they going to describe it to you? Worst pain they ever had. Okay, that makes you really think about other things.
Like sharp.
You're used to a certain headache. This one's different. Okay. Where is it? Where are they going to point to if you had them point? Unilateral. So it's usually unilateral. Are tension headaches unilateral? Not usually. Okay. What else how else could they describe it? Throbbing, pulsating. Okay.
You can also have nausea and vomiting.
Nausea and vomiting, yes. So that's a big one because we'll talk about, because a lot of the drugs we use will also make them nauseated. So we may want to pre-treat them with an antiemetic.
So a lot of the times, you're just getting IV fluids or
Yes, hydration is usually is one of the things we'll tell people is stay hydrated. That usually helps. Bailey, did you have something you wanted to, okay. Anything else? Sensitive to light and sound. So usually what do they want to do? Usually I get to dark, decrease incoming sensations, sounds, usually helps. Okay. What'd you learn about tension headaches? Did you all talk about those? Okay.
they're due to muscle stress.
So it'd be
It's
like
from your neck. Okay.
Like the
It's
back
like a
of your
vein,
neck.
tight
back
muscles.
and like
Okay, tight muscles. Okay, what else? Are most people going to come and see you about it?
No.
No, they're going to pre-treat. They're going to self-treat, self-medicate. So the one thing I would say is then know what's out there that they're usually going to use. Okay. Opioids are the panacea for all of them, right? No. We don't want to use them.
Yeah, what is
pan, so like all.
What's pan mean?
All.
Everything. So panacea means overall, all reaching. What do you all read?
We just agree with everything.
right now?
Okay, so panacea, a one thing fits all, one size fits all. Okay. So what'd you learn about medication overuse? Rebound, what, okay, say more.
Migraines.
Okay, so it can happen, but it can happen with almost any of the headaches. So tension can also overuse. All right. Did you talk about cluster headaches?
Yes.
Okay, so what'd you learn there? Unilateral, where is it mostly on, over the eye? So I have a colleague who has clusters, she's female. So it's usually males, but she's female. She said it feels like an ice pick being driven into your eye. She said it's the most intense pain you can imagine. It's really bad. What's?
Short term, it's like 10, 2 hours.
No, they can last a long time. But yes, they're very sudden in onset, as opposed to migraines can be more gradual and escalate. Cluster headaches usually are just wow, bam. Those all are headaches, I think so, that we're going to talk about. Sinus I didn't cover. Okay, so let's start. Let me just go to page 2, the top. So you said he used this picture? Oh, that one, okay. So the common migraines, so we're going to talk about migraines, tension type, cluster, medication overuse briefly. And I'm going to spend time on menstrual migraines. Did you all talk about that? It is a trigger. It's probably one of the most common triggers in young women. And so we're going to talk about how to manage it. So migraine headaches, I think most of the things you've said. So 3 to 1, women 3 to 1. Mostly in the third, I have third and fourth is what I found, but in terms of prevalence. Lots of disability associated with it. So there's the pathophys. So if you look on the next page, it's probably given you better. At the very top, it's a track. So you have an area of the brain where that cortical spreading depression is how they describe it. So you see how it migrates through the brain and then eventually results in the symptoms at the higher cortical pain areas, and that's when people are going to complain. The one thing I want you to remember is that serotonin is the most important of the neuropeptides, because our drugs are going to go after that. So we use the triptans because they're serotonin agonists. We can also look at ergotic alkaloids. Those are old drugs. They've been around forever. They're effective. They have a lot of side effects with them. So we'll talk about them. They primarily result in vasoconstriction, so that's what our acute therapy will do. Our prophylactic therapy tends to work on other neurotransmitter systems. So propranolol, one of the big ones, or the beta blockers, are going to primarily modulate the effects of catecholamines. They have some serotonin modulating effects, but for the most part, the catecholamines. Okay, let's move over to page 4 then. I'm not going to spend a lot of time on the pathophys, but I gave you some of the layout there. Clinical presentation, so the pre-symptoms can be neurologic, you all mentioned those. So photophobia, so the not wanting to be in light. The phonophobia, the sound, difficulty concentrating. Psychological symptoms that can coexist with them. So these you need to be aware of because the drugs that we use can help with those, augment those, or they can make them worse. So those are one of the ones to pay attention to. Autonomic, so diarrhea, constipation, polyuria. Here, that serotonin system, don't forget that there are a lot of serotonin receptors in the gut. So we'll see this when we get to the next module and we talk about the different antidepressants. Many of them affect those serotonin receptors. And that's why they have a high degree of diarrhea or constipation associated with them, or nausea. And then constitutional. Lots of those are listed. These are just a few that are that I found. Aura, about 25%. So the majority are not going to have auras. 5 to 20 minutes before the headache, should last less than 60. And then visual field, it affects usually half the visual field since it's usually unilateral. So pain is usually gradual in onset. So that's different from the cluster headaches. Peaking in intensity over several hours, usually lasting in the 2 to 3 day range. Can occur anywhere on the face or the head, unilateral, throbbing, pulsatile in nature. You talked about those. GI, usually present. And then there's kind of a postdrome. So this syndrome can leave people very exhausted, tired, fatigued. Okay, so on the next page is the new diagnostic criteria for migraines. You can see at the top is listed common migraines, an old term for it, migraine without aura. So here, their diagnostic starts with at least 5 attacks that have these criteria, have at least some of these criteria. So headache duration of 4, that should probably not be, should probably be 48 to 72 hours.
I think it's 4.
You think it's 4?
I said 472.
But he said the same. It's probably, I think he took it's exactly the same as yours.
You know, mild can last very short, but 4 hours seems really short. I don't know why I didn't catch those with it. So he already gave you these? Yeah. So you've had all these. Okay, I'm not going to walk through them then. Okay, let's go to the next page. Let me, in case he didn't point it out, if you look at migraine with aura on the page again, you've got migraine with aura, and then you've got migraine with typical aura. So the where they differ is under their symptom, aura symptoms. So both of them have visual, sensory, speech, or language, but only the migraine with aura has motor, brainstem, and retinal listed. If you compare it to the bottom with a typical aura, those are not symptoms that are associated with those. The rest of them is all the same. Okay, top of page 6 then. So you can kind of divide, you need to divide the goals into acutely, what are we trying to do? Acutely, we want to make the person comfortable, stop the pain, and get them back to functioning. Long term is the prevention of the frequency, decrease in the frequency and the disability associated with chronic migraines. So, and we need to think about the drugs that way. We have acute or abortive treatment, and then we have preventative treatment for chronic. So for long term, we want to reduce the attack frequency, severity, disability. We want to figure out what are they doing to treat it. So there's lots of things they can use to self-treat. They may or may not be effective. So getting an effective regimen in place is very helpful. Or if they have doctor shopped and they've come around and they've got now just an amalgamation of different therapies that they have tried, then cleaning those out sometimes will help. Avoid acute headache medication escalation. So one of the things we'd like to do is with long-term is get them to decrease the amount of acute treatments. The more times they use acute treatments in a time period, the less effective they become. So getting it down to where those abortive treatments then are effective is one of the goals. Reduce headache-related stress, psychological symptoms, enable them to manage their disease. So this should involve a lot of patient education. So realize that they usually are going to be in families or in a group of relatives that have had these, so they're going to be hearing lots of ways that people manage their migraines. So some of that will be true, some of it may not be true. So patient education is important. And we want their quality of life to be good. We want them to be able to do what they want to do without headaches interfering. Acute treatments, we want to get them treated quickly. We want to restore their functionality. We want to minimize the use of backup methods, rescue methods, minimize the side effects and cost. So cost can be, for the newer agents, can be quite a bit. For the older agents, they're fairly inexpensive. Non-pharmacologic are listed there. The number one is drugs, though. It's hard. You can't manage these usually with non-pharmacologic alone. So hydration, the ice, the dark rooms, avoidance of triggers, the behavioral therapy, relaxation, biofeedback. Cognitive behavioral training is wonderful. It is just very difficult to get people into someone to get it done. There's a limited number of psychologists that do that, and it's very hard. The last time I tried to get somebody referred in, I called in all the people I knew, and they said it's still about 6 months. So it's difficult for this. We're going to see this come up more and more. It's a very good training, very effective, but it's also a lot of psychological and neurologic diseases benefit from it. Physical therapy, there is varying amount of evidence. The things that I'll give you are more evidence-based. Headache diary to identify their triggers if they're not aware. So you mentioned triggers, that's important. If they can learn to manage their triggers, they can learn to decrease the number of times they have it. Okay, so those are our goals. General approach, the mainstay of therapy is drugs. So we have drugs that are acute and drugs for prevention. So with the abortive drugs, so these are the acute, we have migraine specific, so those are the triptans and the ergotamines. And then we have migraine non-specific, so like Tylenol, the NSAIDs, those are non-specific. Both of these are effective. Usually mild to moderate headaches you can use migraine non-specific. For the moderate to severe, you have to use migraine specific, used for most people. So initial therapy, non-specific for mild to moderate that's not disabling. For people who have a lot of nausea or vomiting, that will interfere with the effectiveness of the drug, especially if they do that pretty soon after you give them. So a lot of these drugs have non-oral routes. So there's suppositories, there's nasal sprays, there's subcutaneous injection, there's even parenteral injections with the ergotamines. We would like to limit, if you're taking care of patients who have migraines, then you want some idea of how often they're having to use abortive therapy throughout the month. This says, this is a recommendation to fewer than 10 days per month. Did he talk about that? Does he just do acute mostly? Okay. All right, so one of the frequent use of abortive therapy is going to be a signal to consider preventative therapy. Okay, preventative on the next page, kind of going through general, then we're going to go back through specifics. So preventative is prophylactic, so these are daily basis, whereas the acute is just like it says, you take it only when you need it. So consider preventative when they are having recurring migraines that are significant, have significant disability associated with them. Let's say it knocks them out of work for a day. So you get that 10 times a month, that's a lot. Then you're going to be looking at, can you maintain a job? So looking for our schoolwork or taking care of their family, just having kids and family responsibilities. Attacks that occur more than two times or more a week. Or where we're worried about running into medication overuse and lots of acute therapy. If what we are using is no longer effective, that would be a time to look at another class of drugs for prevention. Or if they have migraine variants that are causing neurologic injury. And then if it's a patient's preference. Medications that are approved for migraine prevention. The beta blockers, there's 3 of them. Propranolol and timolol, metoprolol also falls into that. Of the neurologic, divalproex, also adepocane, and topiramate. Now we've talked about some of these drugs, so always considering what their comorbidities are is important. We'll go through those again, but listen for them when we talk about the different drugs. The other is time frame. Most people will get some degree of benefit in the first month, but it may take as long as 6 months to see full benefit. So anytime so when you get into these situations, it's always letting the patient know what to expect. I expect to see that you are going to get benefit this next month. However, it may take us 3 to 6 months to tell fully whether this will work for you or not. If you set up expectations for patients, they will much more likely believe you and stay with things than if they have no understanding of expectations. So Dr. Britton told me this weekend, he said he talked to you about this very same concept in terms of your believability. Okay? So the more you can project out for patients, here's what he told me, he told you, is that the more you can project out for patients, here's what's likely to happen, the more they'll have belief that you know what you're doing. Many of you will need to buy that because you're so young that older people are going to look at you and go, what in the hell can you know? Okay? When I started out, it's the same way. I started in the VA, and those old men used to tell me all the time, you have no idea what you're talking about. Because the big push then was smoking cessation. They were like, do you smoke? Nope. Then what can you know? Well, I had 2 parents that smoked, so I do have some idea. I got burned more times by my parents would flip their cigarette butts or their matches out the window, and this is before cars had a lot of air conditioner in, and man, those things would whip right back into the back seat where we were all sitting and would burn you. Now my parents were good parents, but I do know some of the fallout of smoking. You get burned with the matches. Okay. So credibility is a lot. As you get older, you'll get credibility just because you're older. When you're young, you really have to spend a lot of time explaining, and then your patients will come along with you. Usually, and you'll see this as we go through, migraine prophylactic doses are usually lower than what we use it for others. So when we see like propranolol, you'll see lower doses than we usually use for cardiovascular things. Now, prophylactic doesn't have to go on forever. Most of the sources recommend going at least a year. They've got under good control, and then, if they're doing well and they're willing, is to then taper them off. or taper them back and see if they can maintain with maybe just very few abortive attempts needed in a month or longer period of time. So it doesn't have to be forever. Sometimes that makes it easier for patients to think, okay, I don't have to do this the rest of my life. All right. Anything I told you that was different from what you heard this morning? Okay. All right, page 8. Let's talk about rescue therapies. So we're going to start with the aspirin, Tylenol, NSAIDs, and then we'll move into the ergot alkaloids and then the triptans. So over-the-counter analgesics, non-steroidals, Tylenol, aspirin, all of these are good for mild to moderate. Excedrin, headache, or what is it? Excedrin, migraine. Good for a good combination of drugs that is very effective. So the first line, they're effective. They're not very expensive. The triptans are expensive. They're less likely to cause serious ADRs compared to the migraine-specific agents. So they're good. They have non-oral routes, so you can get Tylenol suppositories. There's aspirin suppositories. People don't use them very often. Avoid products that contain butalbital. You may still run into patients who are on products that have butalbital in them. They're more highly regulated and they're controlled substances, and we try to get people away from them. They're prone to misuse. They are associated with medication overuse. They will drive you nuts in terms of refills and early refills. So they're quite the dependency that they get. They're not highly dependent drugs, but with regards to headaches, they overuse them and they tend to not work long term. They're almost always in combination, butalbital with aspirin or with Tylenol, and sometimes caffeine.
What's it called?
Fiorinol,
Fioraset.
Fioricet would be another one, depending on whether it's aspirin or Tylenol. NSAIDs are good for the inflammation related to migraines, so that's why they work. So the doses listed here for Tylenol, Tylenol is probably the least of the effective, but if you have someone who is at risk with using a non-steroidal or aspirin, then a Tylenol you can use. Here the dose needs to be pretty high. It needs to be at least 1 gram. Remember the maximum dose? About 3 to 4 grams a day. If they drink, what's the recommendation? Like 2 to 3. So keep that in mind. Older patients may be used to a much higher dose of Tylenol. Used to, we thought we were okay up to 10 grams a day. Okay, so 4 grams is quite a bit underneath that. And then the combination of acetaminophen, aspirin, and caffeine, which is in Excedrin migraine, is a pretty good combination. The caffeine is there. It helps with absorption of the other 2 drugs, and it potentiates the analgesia. I've got that listed somewhere in your handout. 2 tablets at onset every 6 hours until they are done over the counter. So these are all over the counter. Aspirin, 500 to 1,000 milligrams every 4 to 6 hours, max 4 grams a day. You can get into salicylism and salicylate overdose with these, so you have to be careful. Most people can't tolerate it, so they may need to use an enteric-coated product or always taking it with something on their stomach. Cheap. Ibuprofen and Naproxen, these 2 have the most data behind them. Probably as a class, any of them would work, but ibuprofen, the 200 milligrams is the over-the-counter dose. So if they're going to buy them over the counter, then that's the strength they're going to get. If you prescribe them, you can prescribe 400 or 800 milligram tablets. Avoid doses of 2.4 grams per day, so that would be 800. You can't go up to 800 every 6 hours. That's the maximum dose. Naproxen Aleve is over the counter, comes as a 220. So patients who have very mild could use those. Usually using a higher dose in the beginning is best. Using the lowest dose usually doesn't. So usually using a more max recommended initial dose will help to get the headache and their symptoms under better control than if you start very low. So giving them an initial high dose and then having them back off to lower doses for breakthrough or when the symptoms come back. Questions about those? So you've seen that before, you've heard it, you probably know or have experience with them. Now for the migraine specific, here we have the ergo-alkaloids and then the triptans. The ergotamines are old drugs. They have been around forever. So you may have a lot of older patients that are on these. They come in a lot of different dosage forms, so which makes them useful. So under ergotamine tartrate, you have tablets, sublingual tablets, rectal suppositories. So names would be Cafragot, Ergamar, Cafragot, rectal suppositories. You'll see maximums there. You'll see the need to pre-treat, or Cafragot can make them really sick to their stomach. So pre-treating with an antiemetic would be helpful. Again, you see caffeine there. Again, it helps potentiate the analgesia, helps to absorb the drug. The dihydroergotamine is a good one to remember, called DHE, is that it has a parenteral form. It's one of the few. So it can be very helpful if that's the only access. So you can give it IM, IV, or sub-Q. Some of the triptans, Sumatriptan, comes as a injectable as well. DHE is an alpha blocker and also works on serotonin receptors. So it helps with the vasodilation. They cause vasoconstriction. So if you look on the next page, you'll see mostly these drugs have their effects in this disease or condition is on the serotonin receptors. So they vasoconstrict blood vessels. So I got you a little reminder there in the middle of the page. They will constrict venous and arterial. They're usually a little bit better at the venoconstriction. They cause a lot of nausea and vomiting. So if they're coming into like an urgent care or an emergency room, if you're going to use them, then use an IV antiemetic with them. So metoclopramide, prochlorperazine, what's the other one? Chlorpromazine. So compazine, Phenergan, Reglan. Those all come IV. Now, the one thing to remember is all of those can cause akathisias or dystonic reactions. So giving them with Benadryl, and IV Benadryl or IV diphenhydramine, you may want to make a note. I don't think I put that in there. Will help. It's sedating also. It's calming, so it will help them as well. So before the ergotamines, using an antiemetic and diphenhydramine with them if you're going to use an IV. If you look under serious adverse effects, these are important to remember. Because they're vasoconstrictors, they can cause ischemia. So they can cause ischemia anywhere. They can cause it in the heart, they can cause it in limbs, in the fingers, so complaints of cold, numb, pain in the digits or in their feet is called ergotism. So you can precipitate a heart attack in giving somebody these drugs. Paresthesia, diminished pulses, claudication. This is due to the vasoconstrictor. So they're very effective in the right doses, used correctly, but they can be deadly in people who've already got some type of peripheral vascular disease or underlying coronary artery disease. That bullet that's got 2 exclamations in point. Triptans and ergotamines are both potent vasoconstrictors. Don't use them within 24 hours of each other. So, if they're coming into urgent care or an ER, you've got to ask them, what have you pre-treated with? Because if they've got a failed treatment. So sometimes acute treatment doesn't work. If they're coming in because they can't get relief, then you've got to find out what have you used. There's a lot of dosage restrictions. If you go back and look at the page before, max dose for ergotamine tartrate, 6 milligrams a day or 10 milligrams a week. So it's telling you in about one day, one time, you can start to get close to your max. Sublinguals, same as above, and for the suppositories, 4 milligrams a day or 10 milligrams per week. Okay? This is one of those drugs that will give you a lot of rebound if they overuse. So medication overuse syndrome is not uncommon with overuse of ergotamines. Questions about those? Did he talk about treatment? Okay, so what did he say about the ergotamines?
They were older drugs.
They are older drugs. Old does not mean bad.
They didn't really talk about them.
Okay.
He left it all to the users.
Pardon?
He left it all to users.
Oh, okay. So they're ones to keep in your mind. I really would keep them in mind for older people because these have been around very long. The triptans are probably 20 to 25 years, like Sumatriptan. Okay. So moving on to triptans. So these are the serotonin receptor agonists. So they're very specific for serotonin receptors. So they're very effective. They relieve migraines through normalizing the dilated arteries, so they enhance vasoconstriction. They inhibit the vasoactive peptide release, and that's mostly serotonin. And they inhibit transmission through second-order neurons ascending to the thalamus. So if you go back and look at those pictures, you can see the different areas that they affect. They can be used in any degree of migraine, mild to severe. You probably don't want to use them for mild unless people really have lots of disabling symptoms along with their headache. They can be used for rescue, usually is what we use them for. They can be used for more chronic. So principles, it's based on the characteristic of the headache. When we go through the products, I'll point those out. Convenience of dosing, there's lots of different products. And there are some that are very fast in onset and some that are very slow and are better in chronic situations. So there's a lot of drugs in this category, and it pays to know the difference in them because you can use them to your advantage depending on how the patient presents or how they're responding to therapy. Usually pretty well tolerated. They're different in their pharmacokinetics. I pointed that out on the table, and we'll go through that. Page 10. So we can divide them, and I have noted on the table these things. Fast onset, high efficacy means sub-Q Sumatriptan gets you get effect in less than 15 minutes. Then we've got the slower onset and lower efficacy, but they're usually good in people who have more gradual onset, or we want chronic treatment. Or when we get to the prophylaxing menstrual migraines, we'll find some of these drugs have very good data behind them. So just in general, Provatriptan and Naproxen have the longest half-life, so they have the slowest onset. But they also have the least headache recurrence. So best for patients who have slow onset headaches that last a longer time. I always think of Lord of the Rings when I think of Provatriptan. Did you all read The Hobbit and Lord of the Rings? Yes, so I always think of that. Okay, the fast-acting triptans are more efficacious when rapid onset is needed. So Sumatriptan, fastest. one of the fastest. Rizatriptan and elatriptan have rapid onset, usually under 2 hours. Overall, those two drugs seem to perform the best in clinical trials. Sumatriptan and almatriptan they're in the fast response rate, but they're the slowest of that group. And it's not always, individuals don't always read the book and then respond like we expect. Okay? So if one triptan doesn't work, considering another one is a good idea. So they may not respond to one well, but they will to another in the group. Lots of different dosage forms. So there are subcutaneous, that's the quickest. Sumatriptan sub-Q is the very fastest. You got intranasal, so if people are vomiting up their guts, you can use an intranasal. Or there's the orally dissolving tablets. Those may be good if people can't get down any fluid, they can just put it on their tongue and it'll dissolve. There's combination product out there, a really good one, Triptans is Naproxen plus Sumatriptan. So if you have someone who maybe can't tolerate higher doses or doesn't get full relief on either one, this combination is really good. It's one to keep in mind. Another one that does not have a commercial product that I know of is using Sumatriptan plus Metoclopramide. So the antiemetic part in the Sumatriptan. So for people who always have nausea associated, that's a good combination to use. Side effects: paresthesias, fatigue, dizziness, flushing, warm sensation, somnolence. Almost all of them will cause it to some degree. The intranasal are nasty. They taste bad. The more it runs down your throat, they're not very good, but they're very effective drugs. Adverse triptan sensation, this is an important one. Tightness, pressure, heaviness, or pain in chest, neck, and throat are common with the triptans. Adverse cardiac effects: MIs, coronary vasospasm with ischemia, the vasoconstrictor. So get your history. Be cognizant in older people about using these. So what are the contraindications? The first ones are cardiovascular, ischemic heart disease, hypertension that's not controlled, cerebral vascular disease, so they've had a stroke. So avoid it. People are high risk. They may not have it, no known heart disease, but they have lots of risk factors. Smokers, blood pressure, diabetics. Cardiovascular assessment is prior to use is recommended for older women, postmenopausal, so usually 50 and up. Men over 40, uncontrolled cardiovascular risk factors. So that would be what? What are the cardiovascular risk factors? I've already mentioned some of them. Smoking, diabetes, hypertension, elevated lipids. Pardon? Just lipidemia. That one wouldn't worry me so much if they don't have anything else. So it's recommended that people receive the first dose of triptan under medical supervision. I have no idea how many people do that. I would imagine it's close to 0, but it's something to keep in mind. If they have some of the more odd variants of migraines, hemiplegic or basilar, these are contraindicated. Routine use in pregnancy. We don't want to clamp off those arteries to the fetus and the placenta. Do not use within 24 hours of an ergotamine derivative. Some of these don't use them if the patient is also on MAOI. Your brain should, if you see an MAOI, you should be thinking multiple things. What other drug, what am I getting ready to add? If what I'm getting ready to add, is that going to increase norepinephrine or other neurotransmitter amounts? Think. Look it up. I look them up because there's so many that are contraindicated. So don't use Sumatriptan, Rizatriptan, or Zolmitriptan within 2 weeks of an MAOI. Elatriptan is one of the ones that stands out in this group with 3A4 inhibitors. because it raises the level, puts them at more risk. Don't use them with SSRIs or SNRIs. Those are antidepressants. You increase the risk of serotonin syndrome, and we'll talk about that. That is a life-threatening emergency, is serotonin syndrome. So the more drugs you have that add to and increase serotonin amounts, the more likely you're to have serotonin syndrome. It's ugly. People die. Okay, so. And then frequent use of triptans can lead to medication overuse headaches. So that is one of the drugs that sometimes you have to work people off of and replace in order to avoid those headaches. Questions about that? Those are just kind of general principles. Okay. Can you go 5 more minutes, or do you want to break now? Okay, we're going to go through this table in 11, and then we'll break. It's 10 till, so I didn't want, if you're really anxious to go, we'll go. All right, so I have tried to highlight the things on here that are important. One is to recognize, and luckily, they all end in triptan, so you should be able to tell what class they belong to. If you go down through there in terms of time, well, let me go back. Note the different dosage forms that are with them. Sumatriptan has the most dosage forms. So you got Sumatriptan tablets, you've got injection, nasal spray, and the combination with Naproxen. It came out first, it got out of the gates first, so it's got the most. And then Zolmitriptan has the tablets, the oral disintegrating tablets, and that nasty nasal spray. And so does Sumatriptan. They both have a nasal spray. So those are the two. And then Olmatriptan is an oral tablet. Elatriptan is an oral, Provatriptan oral, Naratriptan oral. So all of them come as an oral tablet. Then Rizatriptan has also the oral disintegrating tablet. Maxalt's been around a long time. It's probably one of the second or third one that came out. If you look at time to max, the thing to note is the little notes I put underneath them. Elatriptan, rapid onset of action. Rizatriptan, rapid onset of action. Sumatriptan, onset 20 to 30 minutes. Even for a tablet, it's pretty fast. Sumatriptan injection, fastest onset, 12 to 15 minutes. Sumatriptan nasal spray, it's pretty fast. So is Zolmitriptan nasal spray, rapid onset. If you look over under comments, I've highlighted the ones that are metabolized by MAOIs, or that were contraindicated, sorry. Elatriptan, I've noted don't use them with a 3A4 inhibitor. Provatriptan and Naratriptan, slowest onset of action. So these are the things I'm probably going to use in a question for you to decide which one to use. A lot of the efficacy is dose dependent. So for Sumatriptan, you'll see 50 milligrams listed as a starting dose, but really 100 milligrams is where you get the most efficacy for the tablet. That injection is more, the Sumatriptan injection is more effective than oral, but there's more side effects with it. So higher efficacy usually goes with more side effects. It has in terms of dosing, you can repeat the dose within 1 hour, but they have found that most people who don't fully respond to the first dose, usually the second dose is not that effective, but it still carries that recommendation for a repeat dose. Any questions about those? Know those big things. Very effective class. It's like I told you, anytime you see a lot of them in a class and lots of dosage forms, gold. Okay, well, let's take a break and we'll come back in about 10 minutes.